Good afternoon, everyone. I am Rahul Gosain.
And I'm Rohit Gosain.
And we are Oncology Brothers. Today, we're joined by none other than Dr. Aaron Goodman himself, who's also famously known as Papa Heme, to cover ASH 2022 highlights. There was a lot of data presented at this meeting, but only a handful are practice-changing or relevant for us right this minute as a general hematologist and oncologist. Without further ado, let us welcome Dr. Goodman to walk us through some of these studies.
Well, thank you for having me. Excited to be here to go through some of these studies. They're actually this year at ASH, a lot of times, not much changes with what I do after ASH, but, great science. But there are some things I will now change what I do. So we're going to go over some of those.
Dr. Goodman, we are hoping to focus on 5 studies very briefly. First, looking at restrictive diet, second study in mantle cell lymphoma, and the other 2 focusing in multiple myeloma in elderly and frail patient population, and then the last one in BTK inhibitor in CLL. Can you please start us off with the first study, NutriDiet, and its findings?
Yeah. So, and I'll be brief for you guys. So this was just a little background. I do a lot of transplant leukemia, and some hospitals have already moved away from the restrictive diet, which is avoiding berries, things that can harm people who are neutropenic. So it was a less palatable diet, more cumbersome. But there was a belief that by doing so it would minimize infections in our patients with severe neutropenia. And again, not based off great data, but this was kind of standard practice in many hospitals, actually including even our hospital here at UCSD. We had the lovely neutropenic diet. It always actually caused a lot of confusion for our patients too, like what can I eat or not, and like half the time I didn't even know as a provider what to tell them. But this study tried to answer in a randomized fashion, do we need to do this? And they took 247 patients, and these were patients undergoing stem cell transplantation or high dose chemo, like induction like therapy for leukemias. So these were patients that were expected to have, neutropenic, durable deep neutropenia for at least a few weeks. And they randomized to, whatever you want, a non-restrictive diet to a more restrictive diet. And they basically looked at whether differences in infections and febrile neutropenia. And fortunately, there were no differences in either febrile neutropenia or infections. And then they also looked at patient satisfaction, and patients were more satisfied in general if they were in the non-restrictive diet. So I think this officially puts an end to the restrictive diet and shouldn't even be thought of, and it makes our life easier. And, these patients, if they're going to succumb to something bad, of all the bad things that can happen to them in patients with leukemia and transplant, it's not because they're eating the berry. Okay, we can let them be and let them live a little bit more, enjoy some better food.
And believe it or not only in transplant, but we've seen this even in solid tumors. Some of the hospitals would have restrictions for neutropenic diet, even in that settings. So I think this is great. And of course, one less click for us in EMR.
Yeah.
Dr. Goodman, can we please dive into our second study, which is triangle study in mantle cell lymphoma?
You kind of first need to decide whether you're going to give them more intensive therapy. And when we think of intensive, including high-dose cytarabine containing regimens versus less intensive, more like bendamustine rituximab. Although the two have never been compared head-to-head. Well, there are some studies looking at the introduction of high-dose Ara-C versus not, and it seems to be better outcomes, at least in terms of progression-free survival. And then the next thing, including for people who are treated with intensive therapy, including high-dose Ara-C, is the incorporation of autologous stem cell transplantation. In general, this has been our practice for young, fit individuals based off the progression-free survival. And then in abstract form, recently, there was a potential hint of overall survival advantage with autologous stem cell transplantation. And again, there are many high-dose Ara-C containing regimens, but the ones that the Europeans like to use is R-CHOP, so standard R-CHOP, alternating with R-DHAP. So what this triangle study, their main question was, there was really 2 questions. with the addition of ibrutinib, which is a BTK inhibitor, which is approved in the relapse space. So we know it's active in the relapse space. They were looking to combine it up front, and they were looking, will adding ibrutinib, one question was, will adding ibrutinib to intensive therapy and transplant improve failure-free survival, which is much like PFS, to intensive therapy plus autologous transplant without ibrutinib? And then the more interesting question they asked in this study was, if you add ibrutinib, can you just get rid of autologous stem cell transplant altogether? Okay, so I'm usually critical of these add-on studies because usually when you add an active therapy, it's like, you know it's going to probably improve response rate. But this one's legit because they're actually trying to swap out autologous stem cell transplant with ibrutinib. And, we all know auto is not fun, expensive, requires a hospitalization, and is quite toxic, although ibrutinib is not without its toxicity either. And note that the ibrutinib arms received 2 years of ibrutinib maintenance, so that's not benign also. I want to point out one other thing. In standard practice, we do give rituximab maintenance to these individuals. There were 2 trials, one in the transplant eligible and one in not, where rituximab maintenance prolongs overall survival. So that's a standard of care. So one critique in the study was it was not mandated because during that study, actually, the answer to that question of rituximab maintenance wasn't known yet. It was found during the study. So rituximab maintenance was given at the discretion of the investigator. So not everyone got standard rituximab maintenance, but I believe from the abstract, I think it was like 40 or 50% of patients did. And what all these curves end up showing was that if you give ibrutinib, you can get rid of the auto transplant and expect the same failure-free survival with this respective follow-up. Now, whether that will change with longer follow-up, we don't know. And it also showed that adding ibrutinib to intensive therapy with auto you don't need all of that. It doesn't much improve, okay? So my take-home point is that we might not need to do auto anymore in young, fit individuals, but if you're going to do that, you have to sacrifice ibrutinib. You have to give them ibrutinib. So I plan on now having this discussion with my patients and being like, what sounds worse, 2 years of ibrutinib or the auto transplant? And the potential, we do have more longer-term robust data with transplant, but it's definitely worth a discussion now with my patients. So kind of practice changing. So I think in summary, if you get ibrutinib with intensive therapy, you may not need an auto and you can expect similar outcomes.
Certainly very interesting data. So would you extrapolate this data and use ibrutinib with other chemotherapies like BR, or would you only utilize it with the backbone of R-CHOP or RDHAP?
That's a great question. I'm opinionated on that too. So I would only use it with R-CHOP plus RDHAP. I will. There was another study called the SHINE study that was a randomized study published in the New England Journal where they took non-transplant eligible patients with mantle cell and they randomized them to BR versus BR plus ibrutinib, and their primary endpoint was PFS. Unlike that study, unlike the triangle, which is a good study, the SHINE study is a bad study. The triangle study is good because it is seeing if we can replace auto with ibrutinib. The SHINE study is bad because all they are doing is taking active therapy and adding it to other active therapy and asking if it extends progression-free survival, which we know it will because they gave BR plus ibrutinib followed by indefinite ibrutinib. The standard practice of what I do in clinic is BR followed by ibrutinib at relapse. So it doesn't I didn't need to know that question. That question didn't need to be answered. So I strongly recommend against that approach.
Perfect. While we're discussing all about the BTK inhibitors, this is a great transition to our next study. Is zanubrutinib being compared to ibrutinib in refractory CLL? We know ibrutinib and acalabrutinib are already approved in CLL, and we saw that acalabrutinib uptake was significant because it was better tolerated, particularly the cardiac side effects. But now here we have a new BTK inhibitor. Dr. Goodman, can you talk us through this study and its findings?
Yeah, so this takes CLL in the relapse setting, and I think one interesting tidbit before we discuss this study is many patients with CLL are now getting BTK inhibitors in the front line setting. So this won't be really applicable to them. So there's a lot of people now getting ibrutinib in the frontline setting, but I still think this study answers important questions, and it's a very good study. So this was a randomized phase 3 study in relapsed refractory CLL, and a fair study. They asked simply, they compared two BTK inhibitors head to head, and zanubrutinib is a more potent selective BTK inhibitor with less off-target toxicity, unlike ibrutinib, which has more off-target toxicity and on-target toxicity. It actually inhibits platelet function, more cardiac toxicity, atrial fibrillation. And they asked, is one safer than the other? Is one better than the other? And the bottom line is zanubrutinib was better, at least in terms of progression-free survival. So at the very least, it's equally as active, and it's more active. I mean, it's more active, correct me. They get a better PFS. But what's more important, at least for me, is now that we have all these different BTK inhibitors, acalabrutinib, zanubrutinib, and ibrutinib that are approved, it was safer. And this has been now confirmed across other randomized studies. There was another randomized study in the Waldenstrom setting where there is significantly less atrial fibrillation. You can expect an AFib rate of about 10% with ibrutinib, and with zanubrutinib, it's more like 1 to 2%. And this is particularly important with our elderly individuals. There's also less bruising and bleeding with zanubrutinib. There's slightly more typically neutropenia with zanubrutinib, but it doesn't really mount to more meaningful clinically infections usually with that agent. So for me, this is practice changing. Now, it's practice changing in the fact that if I'm going to use a BTK inhibitor in the second line or third line setting, I will always now reach for zanubrutinib. Now, in the front line setting, I think a lot of people are going to want to reach for zanubrutinib, and I don't think with the FDA, I don't think they'll get approval yet until we have more data. But like, it makes me want to use zanubrutinib more. And I will say, in Waldenstrom's, which I treat quite a bit of, I am never using ibrutinib anymore. I'm using zanubrutinib in all those patients. It's way easier to give. Really, the only place I'm using ibrutinib these days are in graft versus host disease treatment. And, you can't use these other drugs in graft versus host disease because they don't have as much T cell inhibition, unlike ibrutinib. So in that setting, ibrutinib's efficacious.
Perfect. I think we can now switch gears and jump on two studies in myeloma, both focusing on elderly patient population. One looking at the role of the transplant, and the other one looking at steroid-sparing approach in frail elderly patient population. Dr. Goodman, stage is all yours.
Yeah, so this MEL 140, although it might not seem like much, is definitely practice changing for me. So a quick backdrop. So for standard of care for transplant eligible patients would be induction either with a triplet or now even possibly a quadruplet like DARA RVD, followed by autologous transplant, which is typically dosed at 200 milligrams per meter squared, then followed by maintenance with Revlimid. And we have two studies, the IFM09 and the Determination study, both really sister studies that were done in the era of RVD, looking at RVD induction, followed by upfront autologous transplant with MEL200, followed by Rev maintenance. Both studies showed improvements in first progression-free survival. Neither study showed improvement in overall survival. Granted, in the IFM09, just about all those patients got, as they should have, got autologous transplant at relapse. But the Determination study, only 20% of patients got an auto transplant at relapse, which they should have, but only 20% did, although that's useful information. So that study, at least for me, was already starting to question the role of transplant in the new era of Revlimid and Velcade. Granted, yes, you for sure get a longer PFS, but I was already starting to get that inkling of my heart, especially in frailer patients. Maybe I don't need to push everyone to transplant, given that in the Determination, many patients in the control arm never got a transplant. They lived just as long. Granted, they didn't have as long a first to PFS. So now that sets the backdrop to this current study. And my current practice was in those kind of 70 to 75-year-olds who I was a little bit scared of giving MEL200, I would drop to MEL 140. Okay, although with the results of the determination, I was already starting to not do transplant in those patients, meaning the determination was already enough for me to say, if I'm going to dose reduce them, maybe I shouldn't even transplant them because it's not prolonging their survival and there's a lot of toxicity. This study is the nail in the coffin for me for offering MEL-140 and transplants in older individuals. It doesn't even benefit them. It can't even beat Rev-Dex. No way on earth am I ever doing that anymore. These patients will, anyone now who's a little bit frail, my practice will be Dara Rev-Dex. So practice changing.
Just building up on that study's comparative arm, Lendex, and you brought up Dara-Len. This is our next study just next to it, where we're looking at frail population and we're trying to use less and less and less steroids. Your thoughts on this?
This study basically took our standard, well, they took Len plus low dose Dex, which is 20 milligrams. And I will say, we don't give much RD anymore we would probably give Dara Rev Dex, okay? But they compared Len low Dex to Dara Rev, just an itty bitty Dex, just Dex for the first 2 cycles, as opposed to continuous Dex. And they showed very good outcomes for the Dara Rev itty bitty dexamethasone. So this one, I can't say, optimally they would have compared to the Maya protocol, which is Dara Rev Dex for a long time, to this itty bitty Dex, but they showed very good outcomes with the Dara Rev very low little Dex. So I think, what has been my practice is to give the first few cycles with Dex, and I am very eager. Most patients are not getting dexamethasone much after 4 months in my clinic. And I'm probably, with this data, going to eliminate, I look for that excuse to stop it sooner, okay? I still can't say definitively that we can stop the Dex or do no Dex, but we can feel all the data is pointing towards, especially with these novel agents, less Dex. And I think in older times when we had less effective myeloma drugs like melphalan, the Dex was more important. But now with these novel drugs, the Dex is less important. So I still do occasionally see patients that have been referred that have been on Dex forever, and I would strongly advise not to. My current practice is anyone over the age of 40, over the age of 70, I cut the 40 milligrams to 20 and cut the dexamethasone within a few cycles, and this study further supports that of dropping the dexamethasone.
Well, overall, a fruitful conference with some important recaps. Restrictive diet in neutropenic patients did not change outcomes. The other one, ibrutinib, with chemo can be selectively be used in upfront setting in selective mantle cell lymphoma patients without the need for autologous transplant.
Yes.
Data for zanubrutinib is very promising with a better safety profile when compared to ibrutinib. And we have to be very careful in overtreating our elderly and frail myeloma patient population with a focus on less Dex when possible. Thank you so much, Dr. Goodman, for going over these practice-changing studies from ASH 2022.
Yeah, thanks for having me. It was a lot of fun.